All right, Senator Blackburn, who's remote.
Thank you, Madam Chairman, and to our
Thank you.
witnesses, thank you for a very spirited debate. This has been helpful today. Rural hospitals have been one of my focuses, and I wanted to come to Dr. Hockman for just a little bit on this issue. We know that rural hospitals are facing a shortage of health professionals and resources, and COVID has really exacerbated the problems in our rural areas. And sometimes what we have seen in Tennessee is sometimes these hospitals are relying on transfers from larger health systems to care for patients' intensive needs. And so, Dr. Hockman, I'd love for you to discuss for just a few seconds how healthcare systems have come around some of these rural facilities that are in unserved areas and have really kind of helped stand with them during COVID.
Well, thank you very much, Senator Blackburn. I think, what we've seen during COVID is that the rural hospitals needed our help. So whether they were affiliated or part of our network, we hooked up a number of our rural hospitals with telehealth to get the specialists out there. And I think telehealth is one of the things that's going to be incredibly important to rural healthcare. Go ahead.
Go ahead.
And then the other thing I think we need to help our rural healthcare partners with is ensuring that they can get the doctors and professionals that they need out there, because people want to get care close to home. If we lose rural healthcare, we're going to lose something that people want to get care in the communities they live. And also looking at the different models of rural healthcare, what services are needed, what are so if someone is a little bit sicker, how do we ensure that they're able to move seamlessly without an effect on the patient if they need care somewhere else?
And sometimes that takes a larger facility being able to work in coordination with those community health centers in order to get them in there. Mr. Cannon, let me ask you this. You talk about telehealth, we talk about getting healthcare workers into rural areas, and Senator Durbin and I've been working on that. We have legislation that would do that. Let's look at Senator Klobuchar's bill. And if this bill were to pass and be signed into law, what effect would it have on our rural communities that are facing hospital closures?
I apologize, Senator. I'm not familiar enough with the bill to provide an opinion.
Okay, thank you for that. If you would look at the bill, and then I will submit that to you for a response in writing.
I would be happy to do so.
That sounds good. So, Dr. Hockman, let me come back to you. What other options do our rural communities have in seeking adequate health care if their local hospital struggles to remain open and is at risk of closing, and there is not a larger hospital group that they can come under that umbrella?
Well, we're going to need some flexible funding support for those hospitals so they're able to keep their services in their community. We think there's some public-private funding opportunities for those local hospitals. I think we got to be really innovative about rural healthcare. And before the pandemic, that's what we were spending a lot of our time and energy on, was trying to figure those pieces out. I think it's doubly so. And, rural hospitals as well, as mental health problems are paramount, right? And they're having to serve all the patients in those communities. So I think whatever we see in other hospitals is magnified so greatly in the rural community that we really need to put a full court effort on all of that. And that's what we think. It deserves different funding options, different ways to pay for care, different ways to provide personnel and training, and the use of telehealth as well. And then also not necessarily being taken over by large hospitals that we see, let's say in a place like Tennessee, but how do they affiliate in a way that they can be supported so that they can stay independent and take care of their patients?
Yeah. We hear a good bit about that from our rural communities. Another thing that is discussed often is the average out-of-pocket cost that a patient pays. And over the past decade, the escalation rate of that out-of-pocket cost. So, Mr. Cannon, let me ask you this. How has intervention by the federal government into the healthcare delivery system, and especially if we're talking about the last decade, through the Affordable Care Act, how has that caused escalation in cost? How has it caused consolidation of insurance and affected access to care?
As I mentioned in my written testimony and mentioned in my remarks, economist Kenneth Arrow explained 50 years ago that insurance increases prices because it reduces the incentives for patients, providers to shop around for lower cost hospital and surgical care and other types of care as well. To the extent the Affordable Care Act expanded health insurance coverage, there are many benefits to expanding health insurance coverage. But to the extent it did that, it made patients less cost conscious about the care that they are consuming, encouraged that people who were insured to consume more care than they did, but than they would have otherwise, and required them, as mentioned with Senator Lee, to purchase types of coverage that they would not have wanted to purchase. But the main takeaway is that we already paid for a larger share of healthcare in this country through third parties than just about any other OECD country, except for maybe one or two. So patients are more insulated from the cost of their care here in this country than in other countries. And what that does is it puts upward pressure on prices and encourages the sort of consolidation that we're talking about here. The Affordable Care Act has been part of that, not only on the financing side, we've been discussing in coverage levels, but also in some of the regulations that the Affordable Care Act introduced, the minimum loss ratio regulations that I mentioned in my testimony, the pre-existing conditions provisions in the ACA also encourage consolidation in various ways, and I think have similar effects of other regulations that encourage consolidation on prices.
Thank you. Thank you, Madam Chairman. I've got a couple of other questions. I'll submit those for a written response. Thanks.
Perfect. Thank you very much, Senator Blackburn. I think we're coming to an end here. I had one last question here for Dr. Gaynor. And as I look at some of the things that could happen here that are straightforward, we had some good discussions about the resources where there's some bipartisan support. We've talked about some of the labor issues, the consolidation, what's been happening by looking backwards, looking forwards. We talked about the financing at length. A number of senators asked about that and the effect on that as a driver. And my question, Dr. Gaynor, one last thing I don't think we've discussed is in 1996, the Department of Justice, I think people have mentioned this, and Federal Trade Commission issued a lengthy series of guidelines about their approaches to antitrust enforcement in healthcare, covering mergers, data sharing agreements, and multi-provider networks. That's quite a while ago. A lot has changed. Do you think the agency should issue new guidelines on hospital antitrust enforcement? And if so, what should those guidelines include?